Good afternoon, all. Myself, Manisha, currently doing my internship in Dr. Agarwal's Eye Hospital. And now I extend my warm welcome to our today's moderator, Ms. Dipali Sahu. Ma'am is an assistant professor and in charge head of the Department of Optometry. She, she earned her bachelor's degree in optometry from ITM University, Raipur, and her master's degree in optometry from SRU from Jaipur. With over 5 years of teaching experience, she has been actively involved in academic instruction, clinical training, and student mentorship. She is committed to promoting excellence in optometric education and advancing evidence based eye care practices. Her academic interests include clinical optometry, vision science, and allied health education. Welcome, you, ma'am. And in today's session, we are going to see a case report titled Beyond a Squint, presenting by Kishan. Over to you, Kishan.
Good afternoon, everyone. Myself Kishan from Dr. Agarwal Institute of Optometry. I will share my screen now. There are many pediatric cases in a hospital. One of the different cases are beyond a squint, a pediatric case with multiple ocular anomalies. Introduction. Pediatric strabismus is the misalignment of eyes and its visual axis, which affects approximately 4% of the children worldwide. Persistent ocular misalignment can impair binocular vision, stereotypes, and lead to amblyopia if untreated. Strabismus may occur alone or be associated with congenital ocular anomalies, refractive errors, retinal, optic nerve, or neurological disorders. Early comprehensive ocular evaluation and timely intervention are essential to identify underlying causes and optimize visual outcomes. Pediatric strabismus are diagnosed at the age of 2 to 5 years mostly. Even though the strabismus are identified, they are left untreated, which can lead to many ocular anomalies. Okay, now let's go on to the case. A 4-year-old female child was brought by her parents with the chief complaint of deviation in both eyes in childhood, with no history of any glasses, contact lens usage, and trauma or surgery. She was affected by no diabetes mellitus, hypertension, cardiovascular disease, asthma, or any other conditions. There is no family history of retinitis pigmentosa, glaucoma, or congenital cataract. There are no currently aware allergy history. Birth history. No maternal complications such as diabetes mellitus, hypertension, or thyroid during birth time. Full term baby delivered by normal vaginal delivery. Apgar score was unavailable as reported by the parents. No history of torch influence. Birth carry was immediate. Birth weight was approximately 2.3 kg with no NICU admission. Parents noticed abnormal eye movement within the few months of life, and ocular deviation became obvious during infancy. Vaccinations are up to date as per the national immunization schedule. The unaided visual acuity for the right eye of the patient was 3 by 60 for the distance and for the near N12. And for the left eye was 1 by 60 with the near as N12, no improvement in the pinhole. The intraocular pressure was examined by the application tonometer, which shows the right eye value of 16 mmHg and left eye value of 20 mmHg. Examination under anesthesia. The retinoscope value showed plus 0.50 spherical and minus 2.50 cylindrical power at 180, and the left value of minus 1.50 spherical and minus 3.00 cylindrical 180. Patient was not cooperative for any other orthotic test. The only test done was modified Klimsky test, which shows left convergent strabismus of 50 prism diopters base out. The slit lamp examination of the right eye revealed that epicanthal folds are present with normal cornea, conjunctiva, and sclera. The anterior samples are normal with no cells and face. Pupil size was normal. The pupil size was abnormal with few persistent pupillary membrane present. Iris partial aniridia was present and lens has anterior lamellar cataract. The left eye slit lamp examination showed epicathal folds along with esotropia, normal cornea conjunctiva and sclera with anterior chamber normal with no cells in place. The pupil size was normal with few persistent pupillary membrane present. Iris was showed partial aniridia with anterior lamellar cataract. The slit lamp examination revealed bilateral partial aniridia with PPM and rotating nystagmus. Anterior pyramidal with late lamellar cataract and epicanthal folds. Fundus examination. The right eye showed media clear with fundus reflex present. Maculas present, blood vessels are normal, optic disc size were medium and normal. Optic cup disc ratio was 0.5 mm with fundus under normal limit. The media were clear, fundus reflex present, but macula examination showed mild foveal hypoplasia. Blood vessels are normal with optic disc and optic cup disc ratio 0.6 mm. The fundus was under normal limit. Ophthalmic investigations journal B scan, where the report shows normal vitreous structure with along with the axial length of the eyeball. The specular microscope reveals the endothelial cell count important for the proceedings of the cataract surgery, with cell density of the right eye up to 3023 mm square and left eye up to 2318 mm square. The OCT macula imaging shows the central retinal thickness of the right and left eye are 300 micrometer and 295 micrometer, which is under normal limit. But shallow foveal pit is observed in the left eye. Other investigations such as pentagram and IOL master are done to check the corneal curvature and IOL power calculation. The patient was diagnosed with unspecified infantile and juvenile cataract, both left eye and right eye, monocular esotropia left eye, aniridia and rotatory nystagmus. The treatment which was done for the patient was phacoemulsification with foldable IOL, left and right eye with Mosher's ring under guarded visual prognosis. Strabismic surgery for the left eye under general anesthesia. Phacoemulsification with foldable IOL implant is a cataract surgery in which ultrasonic energy is used to break up and remove the cloudy lateral lens. Through a small incision, a foldable intraocular lens is then implanted to replace the removed lens, restoring the eye's focusing ability and improvising vision. A Mosher's ring is a capsular tension ring with an artificial iris diaphragm used to stabilize the capsular bag and improve visual function in patients with iris defects such as aniridia. Strabismic surgery, also muscle resorption, is a strabismic procedure that strengthens an extraocular muscle by shortening and reattaching it to improve ocular alignment. This was the picture after the surgery. Due to limited patient cooperation during photography, only a representative post-operative image is available. Prognosis and follow-up. Visual prognosis is guarded to fair due to associated congenital ocular anomalies such as aniridia, foveal hypoplasia, and rotating nystagmus. Post-operatively, visual acuity improved to 6/60 in both eyes with improved ocular alignment following cataract and strabismic surgery. Amblyopia therapy and refractive correction are advised to maximize visual potential. 6 months follow-up is recommended to monitor visual acuity, refractive status, ocular alignment, IOL stability, and IOP for early detection of glaucoma, particularly due to the increased glaucoma risk associated with aniridia. Strabismus in children may be first clinical sign of underlying congenital ocular anomalies rather than an isolated condition. In this case, though the parent came with a complaint of deviation, The comprehensive examination revealed bilateral congenital cataracts, partial aniridia, rotating nystagmus, persistent pupillary membrane, and foveal hypoplasia. Early surgical intervention and appropriate refractive correction help to improve ocular alignment and support visual rehabilitation. Timely amblyopia management and regular follow-up are essential to maximize the child visual potential. These are my references. Thank you.
Thank you, Kishan. Thank you for presenting the case reports, and it was a detailed one. And over to today's moderator, Ms. Dipali ma'am.
Yeah, ma'am. Kishan,
Yes, ma'am. Good afternoon, ma'am.
good afternoon. Kishan, what is the degree of present in the particular children?
50 prism
Degree of
diopters, ma'am.
strength. Yes,
50 prism diopters.
50 present after. In a
Yes, ma'am.
Husband test, how many degree present in a degree?
In terms of degree,
Yeah.
It's
You have
30
done
degree.
the Husband test or not?
We have moved directly to the modified Krinsky test, which is under the iceberg test, ma'am.
Okay.
The prismatic deviation is the normal angle of deviation is 30-degree diopters. I think so.
Okay, 30 degree. Okay, okay. So,
Okay.
30 degree both eyes or only one or another eye,
No,
right?
left.
Left eye, which only
As I
left
mentioned
eye.
in the PPT, the left eye was affected, ma'am. Left convergent squint.
Okay, convergence. Okay.
Yes.
And conjunctival is normal.
Shall I show the presentation, ma'am?
Yeah.
Okay.
Why cycloplegic refraction is important for a squint patient? Hello.
Yes, ma'am. The retinoscopy was done under the cycloplegic drops only, ma'am. Under anesthetic, under cycloplegic only the retinoscopy was done.
Mm-hmm. Why it is
And
important
the
for
values
a strabismus patient?
To discover any accommodative parameters involved, the cycloplegic reflection is important, ma'am. So the excess strabismus can be miscalculated.
Okay. How many degrees are present during the Herzberg test or grade of Herzberg test? You can explain me?
During modified Krinsky test, the patient accepted the patient's corneal reflex was aligned at 50% diopters, ma'am. And the iceberg test normal value shows 30-degree angle of deviations.
Okay. I'm asking about if the patient is having a 70 degree. Okay. In a Herzberg test, corneal reflex is 70 degree in a particular patient. So what is the location of the torch light?
And the reflex will be at the sclera, ma'am.
70 degree. 70 degree. If the
Yes.
patient is having a squint and we are found them 70 degree of squint, then what is the location of our reflection?
Yes, ma'am.
From the
That's only, ma'am.
center
The
of
reflection
pupil to
will.
the scleral. Yes.
Yes, ma'am. The reflection will be at the scleral area, ma'am.
Reason. Okay, okay.
Yes, ma'am.
And how do you assess visual acuity in an infant or a young children?
We have used Leah symbols chart to analyze them. We have showed the Leah symbols chart and demo card in their hand, ma'am. We have instructed them to tell about the identical images from the chart in their hand note, ma'am. So you assess the visual acuity using the Leah symbols method.
Why is early diagnosis important for this strabismus?
Okay. The early diagnosis of strabismus, the parents came with the complaints of squint. But after the identification, we have examined that many ocular conditions were found out, like in unspecified infantile and juvenile cataract, monocular isotropia. That's the main case. The parents came, aniridia and rotatory nystagmus. Even though the parents only came for monocular isotropia, we have found cataract along with aniridia and rotatory nystagmus. So early diagnosis is required to correct the visual acuity and ocular and visual functions beforehand. Am I audible, ma'am?
Yeah. Can you explain me a difference between covered and uncovered test,
Okay, ma'am.
which is
During
used
cover
for
test,
the tropias?
yes, ma'am. During a cover test, we will notice the uncovered eye to found covered eye to found any trophias involved. And
Covered
during an
eye is a
uncovered test,
normal or yeah?
sorry, ma'am.
Covered eye is a normal or a squint eye?
Yes, ma'am. So you are
Which
asking.
I'm asking what is covered and uncovered test, and for tropias, what is the test we are used?
For tropia, uncovered, the difference between cover and uncovered test is during cover test, we will cover the eye and see the uncovered eye for any tropias, any deviation present. During
Okay.
uncovered test, we will check for the covered eye. We will cover the eye and remove the cover from the eye to check for any latent squint present. And what is the other question you asked, ma'am?
Which one is used for the tropias to identify
Um, uh,
tropias in a
to
patient?
identify tropia, cover test is the most important one.
Will be used. Huh? Okay. In the case of strabismus, if the patient is having a cataract or other anomalies, then what will be treated firstly?
In this case,
In
cataract
this
was the
case of
primary reason treatment. We have thought that the main reason for the esotropia or tropias, any other tropias, the secondary cause is the main reason. So the secondary cause can be treated first, and then we will see if the squint naturally corrects itself, or we should proceed with any surgeries for that.
okay. Uh, what is the occlusion therapy? Can be used only occlusion therapy for the correction of the or alignment of the strabismus without surgery?
Yes, ma'am, we can use the occlusion therapy, but occlusion therapy can be used only for convergence or divergent type of squint, like muscle spasm, pseudostrabismus, like that. For that type of squint, we can use occlusion therapy, where the normal eye is occluded to fixate the squinted deviated eye repeatedly for to maintain the visual access, ma'am. So the area where the normal surgery is required and occlusion therapy is required is based on the curse of the squint, ma'am.
Okay. Tell me about Botox injection. They are helpful for the strabismus or any
Yes, ma'am.
improvement of
Botulinum
the
toxin.
ocular.
So botulinum toxin injection is used for as a temporary relief for the squint surgery, squint or deviated eye, ma'am. They will be to avoid any cosmetical appealing cosmetical for the cosmetical treatment, or for temporary treatment, we can use botulinum toxin to paralyze the antagonist muscle and treat the squint for a temporary cause. But we cannot rely temporarily, say permanently on the injection.
This 4 year children, what you are advised for the treatment? They are
Yes, ma'am. For
implemented
the
your treatment or not?
Yes, ma'am. For the 4 year children, we have for the 4 year children, we have used treatment. First of all, to remove the cataract and place the IOL lens using phacoemulsification along with the Morses ring, ma'am. And then surgery to align the squint. And after that, we have used amblyopia treatment to avoid the lazy eyes cause, ma'am, and also to maintain to regularly monitor the IOP for the glaucoma management. These are the treatment and management procedure we have did for the 4 year
After
children.
treatment, what is the spectacle power they have? After treatment, after surgery or whatever you do, after
Yes,
treatment, what the spectacle power they have recently?
Since we have implanted IOL in the we have implanted IOL in the lens, antivirial lens, ma'am. Since we have
The power
implemented the
they
IOL, we have used the power along with the corrections to the IOL, ma'am. So we don't need any correction for now. But after the review, we will check for the vision and correct them. They have
after
not yet
surgery they are
come for the review.
okay. After surgery, their vision will be improved or not?
Yes, ma'am. The vision has improved, ma'am. Here I have
Improved,
used
na?
in the PPT.
And
The vision has
misalignment correct, na?
Yes, ma'am. The vision has improved from 3/60 to 6/60 in
First,
both eyes, ma'am.
okay. Okay.
Okay.
Over to you, ma'am.
Thank you, ma'am. And thank you, Kishan. Thank you for presenting the detailed one. And can you please give a very brief summary of this case report so that the few interns were joined to the YouTube live as well, and other major parts of chunk of participants were through the Zoom call as well. To all the participants, just give a very brief summary about this case presentation.
So before that, I'll really like to thank Kishan that he was able to answer all the questions that was asked. So good job, Kishan.
Thank you, ma'am.
And thank you, Ms. Dipali, for joining our session.
Welcome, ma'am.
Okay. Yeah, so thank you so much. So I'm sure that based on the question answers that everyone has had, I'm sure that you will have a wealth of knowledge gained. And if there's any other questions or doubts, you can post in the chat box. Meanwhile, yes, over to Om Priyash, he can give a summary.
Yes, Kishan. Just
Ma'am,
provide us a
can you
very
repeat?
brief.
Yes, ma'am. Can you repeat what I should say, ma'am?
Brief of the case report presentation, the summary of it.
Okay,
Summary
ma'am.
of the case report you presented, right?
Okay, ma'am. The patient the patient was brought to the clinic with the complaint of deviation squint in both eyes since birth, with no history of any glasses, contact lens, or any trauma, with no history of diabetes mellitus, hypertension, cardiovascular disease, or no family history of any ocular conditions. The birth history are all normal, and the birth weight is 2.3 kg. Even though the primary complaint is deviation, we have noticed the visual acuity to drop of about 3/60 in both eyes, and the intraocular pressure to be 16 mmHg and 20 mmHg. The modified Krinsky test showed left convergence strabismus of 50% diopters. Under further notification in slit lamp examination, we have found that there are multiple ocular anomalies such as epicanthal folds, a few persistent pupillary membranes, partial aniridia, and anterior lamellar cataract. And for the left eye, we have found the esotropia and the same condition as the right eye. The fundus examination showed normal right eye, but left eye has of mild foveal hypoplasia. There are many ophthalmic investigations done, such as B scan, specular microscopy, OCT macula, and pachymetry ion master. After all the ophthalmic investigations, the patient was diagnosed with unspecified infantile and juvenile cataract, monocular esotropia, aniridia, and rotatory nystagmus. The treatment done for the patient was phacoemulsification with foldable IOL implant plus Morses ring under guarded visual prognosis and strabismic surgery. The normal strabismic deviation, which was reported by the parents under the normal strabismic deviation, which was reported by a parent under a comprehensive examination, revealed multiple ocular anomalies such as bilateral congenital cataracts, partial aniridia, rotatory nystagmus, persistent pupillary membrane, and foveal hypoplasia. And after all these procedures, the patient was visual acuity improved to 6/60 in both eyes, and the eye is aligned properly. The patient was then instructed to 6-month follow-up with amblyopia therapy and IOP management for early detection of glaucoma. That's all for the summary.
Thank you, Kishan. Thank you for providing us a detailed one, as well as apart from the squint evaluation, you also mentioned about the other parameters like other disorders. Also, you mentioned it's a beautiful case to learn about this during an internship period. So, thank you all. And if you have any doubts, you can post in a chat box. We'll open for other 2 minutes for the Q&A sessions. If you have any doubt, you can post in a chat box. So, dear participants, repeating again, if you have any doubt, kindly post your questions, queries in the chat box, or else you can unmute yourself and ask the question. If there is no any doubt, we'll end the session. So thank you, participants. Thank you for joining with us. And as informed before, this will be telecasted in the YouTube also. So we'll be sharing the link in the WhatsApp group. So you can also revisit this case report. You can also revisit and see the case report presentation if you want in a later way. And you can also share this link with your interns, co-interns to watch this case report.
Thank you so much, Dipali ma'am, for joining us with today. And thank you. And I also thank Jemima ma'am for your constant support, ma'am.
Thank you.
So
Thank you all. We are
everyone.
ending the session. Thank you, Dipali ma'am. Thank you for joining with us. And thank you, Jemima ma'am. And thank you, dear all participants. So we'll meet you in the next case report presentation on the August month or the every Thursday, every Wednesdays, third Wednesdays. Thank you. Thank you all.